Our first presenter in this last session is Stephen Schondelmeyer, who's professor of pharmaceutical economics at the University of Minnesota. Please welcome him.
Thank you, sir. Good morning. Welcome to Minnesota, yeah. I have to use the lingo. I'm actually from Missouri originally, but I've been here long enough. I've fallen into the trap of saying Minnesota, yeah. I'm from Missouri, though, and that's to say I'm from the Show Me state. And the topic we're going to talk about has a lot to do with show me. Show me what the price is. Show me what the cost is. Help me make wise decisions as a patient, as a provider, as a healthcare decision maker. So we're going to talk about the value of choice. It has to do with life, death, and drugs. Actually, drugs are ubiquitous in society. And I want to ask you a couple of questions. I always ask my students, is there anybody here that's never been sick a day in your life? Raise your hand, please. Let me see. I don't see any hands. Either you're tired or some of you have had illness. Second question I would ask, is there anyone here who has not needed or used a prescription drug ever in your life? Raise your hand again. I don't see any hands. The point of this is that virtually everyone needs, has used, or will use drugs in their life. Drugs are essential to healthcare. They're very valuable. They help us solve many, many problems. But they also are causing some problems in the healthcare system today. They can cause adverse effects. They can cause access issues because they're not affordable in some cases. So we value drugs, and we'll talk about value in a minute, but we also need to understand and make sure that they're being used appropriately and that people have access to them. Now, what are the driving forces for healthcare expenditures today? On the one hand, we kind of fool ourselves. We tell ourselves that drugs are only 10% of the healthcare dollar. And I'm a pharmacist and an economist, and normally I'd show you an obligatory graph that the economist has to use, but I won't do that today. But drugs are 10% of the healthcare dollar, but the way the Office of the Actuary accounts for that, that's only outpatient prescription drugs. Actually, if we look at drugs provided by physicians in their offices, provided in hospital outpatient clinics, provided by dentists, provided in the hospital, provided in other settings, drugs are 18 to 20% of the healthcare dollar. And the fastest growing part of the drug spend is in the part that isn't in the 10% reported by the Office of the Actuary. So the fastest growing part is kind of hidden from us, kind of sub rosa, and we don't realize it's out there. In society, we have growing needs and also growing technology, which is great, but we also, as a society, are coming to grips with the fact that we have limited resources. If you've listened to debates in Washington over the last couple of decades, they spend more time arguing about where to cut programs rather than where to fund programs. So we have limited resources, and our current growth of spend in healthcare probably is not sustainable. At some point, it's going to have to level out or at least slow down, continue to slow down. So how do we do that? I want to ask you another question, and I ask my students this, and I want you to take this seriously. How much is your life worth? If you went to see a physician over here at the Mayo Clinic today, and they told you, you have a serious condition, you'll be dead within a year, but we have a drug therapy that will make that go away completely. How much is that worth to you? Your life is dependent on a drug. How much is your life worth? How much would you pay for that? I want you to get a concrete number in your mind. Okay? Everybody get a concrete number in your mind. Then the next question I ask my students, how much do you have in the bank? And can you afford yourself? Now, the reason I ask this is to help people realize if our expectation of how much my life is worth and how much I or somebody should spend to save my life is greater than what I have as resources individually, and more importantly, if it's greater than what we have as resources collectively, it means we have a problem. We have a structural imbalance in our economy where we have more expectations than we do resources. Well, in many ways, healthcare is playing that game right now, but it's starting to catch up with us where we're beginning to say the limitation on resources is going to affect how we deliver and provide healthcare, which means policymakers can cut benefits or beneficiaries or payments to providers, and none of those are real palatable. Or we can try within the healthcare system, working with patients and consumers, to use resources more wisely. I think that's the path we need to try first because it has the least effect on patients and providers and others, but it helps us to deliver the same or more health care for the same or less cost. So what happens when our expectations exceed our resources? Our choices will not be sustainable. What we have been doing probably won't continue. We might continue another 5 or 10 years, maybe 15, but we can't grow to the point where healthcare, which is now about 18% of the healthcare dollar, we can't grow to the point where it's 100% of the nation's economy, because there are other things we spend money on, like housing and food and clothing and occasionally education and entertainment. So healthcare can't consume all of the nation's resources. So where will it level off? I don't know if it'll be 20 or 25 or 30 or 35%, but I'm pretty sure it'll level off before 75 or probably before 50%. So there's a natural limit coming. So now let's talk about, we've raised the issue of value and life and death. What's the value of a life? So I tried to look at research that's been done in various parts of the economy and see what kind of value is placed on a life saved. So for example, the EPA, when they reduce toxic substances and save lives, they've estimated the value of a life at $5.5 to $7 million for a life saved. The Department of Transportation has put the number around $6 million. I found studies at FDA that talked about lives saved, and they were valued at about $7.9 million. So you kind of get the range. $5 to $8 million is the value of a life. Now, that's not to say that's what your life is worth, but that's what we've put economically on the value of a life within the U.S. Now, if we applied this same information to other countries, they would probably come up with different values and different ways of assessing that. We can also reduce this question to what's the value of a year of life, and that could be just a calendar year, or in healthcare we have the concept of quality-adjusted life years, which is how functional are you during the time that you have. And in 1990s, we set the value of a year of life at about $50,000. I found in the literature in the 2000s it was up to around $100,000. And in 2012, I found at least one study that placed the value of life at $129,000 per year. Now, let's put this in perspective back with some empirical data. What's the median individual income in America today? Well, the value of life to us would be priceless, but the median income in America is about $52,000. So we start to face the question of, what does it mean when we put a higher value on life than the median income within society? And again, where are the extra resources coming from? How do we rationalize that in healthcare? So we're going to talk about the value of life versus the value of a drug. And we have some interesting ethical policy dilemmas that come up. What does it mean when the annual cost of a drug is more than the annual median income in the U.S.? So we have drugs today that cost $100,000, $200,000, $400,000 per annual course of therapy. And if the median income is $52,000, what does that mean? Now, I'm not saying we should quit using those, but I'm saying we need to have better systems of evaluating value and price and giving feedback in the marketplace for what we pay for those drugs. I think the pricing structure has outrun the resources, and yet our ability to make decisions and communicate value back to the producers hasn't caught up with that. What does it mean when the cost of drug therapy in total for a patient in their whole life is greater than $1 million or $5 million or $10 million. Again, when the cost is more than what we valued the lives at. Interesting dilemmas. And then in the limited resource era, what does it mean? And who do you treat? If you have $500,000, do you treat one patient with a drug that costs $500,000 like a hemophiliac patient? Or do you treat 1,000 patients with a drug that costs $500 per month, like diabetic patients you could treat easily for $500 a month in most cases. So how do you make trade-offs between, when you have limited resources, who do you treat and how do you make those choices? I am not asking you, I'm not prejudging or telling you what choice to make, but we will have choices like this as we proceed in the healthcare system, and we don't have the decision-making tools to deal with it. The other thing we have to realize is that healthcare is not a free benefit. We've grown up in an era where we expect healthcare from our employer, and it's provided to us, and that's great for many people. And then for those who don't have it, for the indigent, for the elderly with limited means, we provide government programs such as Medicare and Medicaid that give health care to various populations. But health care is not a free benefit. We need to reset how we view the cost of health care. For example, I'm always frustrated when I see reports in the newspaper about a drug that's come on the market and a drug company has coupons that reduce the copay to zero, and they say, well, this drug is wonderful and patients can all access it because it's $0 copay, and isn't that a wonderful savings to the healthcare system? What they don't tell you is, often that drug with a coupon from the manufacturer that wipes out the copay may reduce the copay from $15 to zero, but that may be for the patient to use a drug that costs $500 a month when there was another drug that was safer and more effective that only cost $50 a month. And somebody ends up paying that, and who that somebody is the employer or self-insured party on the commercial market and Medicare and Medicaid on the government market. And so they pay that during the year, and then the insurance premiums go up the next year. Now, have you heard the news today about the insurance premiums for the MNsure program for Minnesota's exchange? Premiums are up, 14 to 49%. Part of that's because coupons and other things are inducing behaviors in the healthcare marketplace that aren't economically rational. It looks like the consumer saves money when they don't have a copay out of pocket, but they pay that premium if it's a commercial product at the end of the year, or their employer does, or we as taxpayers pay it for Medicare and Medicaid. So we need to look at behaviors that affect not just out-of-pocket costs, but total insurance premium cost, insurance that's paid by the employer. And employers have a trade-off. If the insurance costs go up, they may decide to continue paying the premiums for their employees, but they make a trade-off. I don't have as much to give them in salary versus paying their insurance premium. Or they could turn to the consumer. At some point, employers will get fed up with this system and say, enough, I'm just going to give that money to my employees and let them go in the health insurance exchange and find their own insurance for health care. So I think we're kind of at the edge of that process today. And then there are the tax-supported government programs. But if you look at all of these, ultimately all of these, either directly or indirectly, come out of your pocket. Either you paid it up front, you paid it in a premium later, or you paid it in taxes. So these are all real costs to us, and just because they aren't present at the time we use a healthcare service doesn't mean they aren't present and affecting us totally. So who makes the value decision for healthcare and drug therapy in particular? Does the patient? Not really. They don't know the costs when they get a medication prescribed or go to the pharmacy. Does the physician, pharmacist, or nurse? They may have some role. They may know that a drug's available generically and prescribe it, or that one drug costs more than the other, but they don't know the absolute and relative prices typically. And they often don't know the behind-the-scenes rebates and discounts and the real net cost of the insurance program, because those are hidden and those are proprietary and they can't be released. So on the one hand, we hide prices from healthcare providers, and then we expect them to make value-based decisions. Can't be done. You can't make a value-based decision without the price. Payers, health plans, employers have a role in this also. But for example, I've started working with some employers to look at the amount they spend on drugs in the medical benefit. It's difficult to find, and their medical plans don't want to tell them or don't have the information, and it's difficult for the payer to find everything they need to find to make wise decisions. HMOs, pharmacy benefit managers, have another piece of the data pie and could tell us, fill in some of the blanks, but they don't have the whole picture either. The pharmaceutical companies make their own value decision about a drug. What is it worth to their shareholders, and how much are they going to charge for it? But that isn't the same as the value to the healthcare system or to society, and we need to view those as separate choices. CMS, the FDA could have a role, but really they don't. First of all, CMS has been told by Congress you can't negotiate drug prices. Second, FDA has not been authorized by Congress to look at economic factors anywhere in their process. Their authorizing legislation does not have the word economic or cost anywhere in it. So there's no clear value decision maker related to drugs. Is it any wonder that we see drug prices just kind of running amok and not having rationality to them? It's not surprising. The market simply is not working well. So who should decide on the value? Well, I think the answer really is all of the above, and we need to do all we can to activate all of the above. Do you know who this is? Okay. If you didn't 2 weeks ago, you probably do now. What does he have to do with drugs? This is this Martin Shkreli, CEO of Turing. He's the guy who raised the price. He bought a drug in a few months ago, raised the price about 5,000%. Now, he's been the lightning rod for a lot of issues about the rationality of drug pricing. But there have been many, many examples of this type out there. He's not the first, he's not the last. I'm not defending or excusing him. I'm just saying he's become a lightning rod, but he's not the sole source of the problem. So let's look at the annual cost of multiple sclerosis therapies. Would you expect prices to go up or down as we have more competitors come in a marketplace? Normally, what would you expect? Well, here, and I apologize, this is not readable, but just look at do you see a trend line here? Okay, and notice there are more entrants in the market, 8 or 9 players. So as more people came in the market, not only did the new ones come in at higher prices, but all the rest followed them right on up. I was actually at a congressional hearing once testifying along with the CEO of a drug company, and he was asked, "Why did you raise your prices, sir?" And he said, "To keep up with the competition." He raised his prices to keep up. Usually you say you lower your price to keep up with the competition, but pharmaceuticals seem to defy the normal laws of economics. So the market is broken. There's a lack of transparency, what we call information asymmetry. That is, the seller knows a whole lot more about it than the buyers. Inelastic demand, lack of negotiation, high barriers to entry, IP. Now, I believe in drug companies and innovation, and I'm not against profit or the free market at all, but this isn't working like an economic market. It's not working with the right signals. This slide I just put in, it will be available for you. It lists on the left various therapeutic categories, in the middle some drugs, and on the right the annual cost to Minnesota-based employers in the last year or two. These are all drugs that cost anywhere, there's one actually for $1,000 and $6,000, but most of these are $10,000 to $500,000 per year annual cost. And again, remember the annual median income is around $52,000. So most of these drugs cost more than the average annual income of a person in the U.S. A quick point about multiple sclerosis. At the University of Minnesota, I help manage our drug benefit. We have 40,000 covered lives. We have about 60 patients with MS. About 2/3 of those are being treated. We look at the total cost is around $52,000 per person per year. That's about $2 million total. When we multiply that out, it adds $52 to the insurance premium each year to all university-covered lives. $52 for 40 patients. The Hep C drugs added another $1.7 or $8 million and added about $38 per life per year to the insurance premium. So 2 drugs for 55 patients out of 40,000 added almost 10% total cost to our insurance premium. we can't sustain new drugs with those prices at that rate. It simply, it can't be done. Now, new drug therapy is not just a matter of price, but rather the value delivered for that price. Providers need to be value conscious and to consider price in decision making. Price is not the only issue, but price is always an issue in value. I can't tell you how many times I've had healthcare value discussions where nobody ever mentioned price or cost. Again, it's not the only issue, and it should never be the only issue, but it always has to be in the discussion because value can't be defined without price. We need to change our decision-making from evidence-based care to evidence-based care, where we look at real outcomes and real cost and real net cost along the way, not just list prices and fictional prices. And health informatics, electronic records can help support a lot of this. There's a cancer drug that significantly extends the life of a patient by 3 weeks. It statistically significantly extends the life by 3 weeks. It costs $300,000 to $400,000. But the patient's laying in the bed without the cancer drug, the patient looks like this. With the cancer drug, the patient looks like this, and they live 3 weeks longer. Now, what's the quality of life here? Was that worth $300,000 to $400,000 if that was you in the bed? Would you want to have your life prolonged to live 3 more weeks like this? I can't answer that for you, but I think we have many places in the healthcare system where we expend money piling on the services that really don't add value to the patient and add major cost to the system, and we haven't evaluated. So what's the value of the drug? When should you use it? There's some great tools that have come out. The Center for Health Policy and Outcomes at Memorial Sloan Kettering has come out with some rating scales to evaluate oncology drugs. And here's a list of factors they take into account. Graphically, they show those as efficacy, toxicity, novelty multiplier, cost of development, rarity multiplier, and then population burden of the disease. And they come up with a total price at the end of what they think the drug is worth, not what the manufacturer charges for it, but what they think it's worth. And then you can compare that to what's being charged and make wise decisions in healthcare. Consumers have the same opportunity. Consumer Reports has a Best Buy drug process, and they have 3 stages, and this is done based on evidence-based medicine, done out of Oregon Health Sciences University, and then Consumer Reports takes it and writes it in consumer language. They have a condensed report that's 2 pages, a full report that's 20 pages, and then a condensed summary table that's usually 1 to 2 pages that shows prices. And the Best Buy, I'll just load these out. This slide shows all the therapeutic categories they have. This information is available online, free. I encourage you to look at them. It's a great tool to hand out to your patients if you're a provider and you have a new patient on one of these disease states. It'll help them understand the disease state, the drugs available, how to make rational choices in terms of cost of those drugs. This is what the cover page of a report looks like. And then the detail looks like this. And they always identify within here based on safety and effectiveness, evidence-based first, and then they look at cost, and then they determine a Best Buy drug. Notice the Best Buy over here on the left, the red markers, and then over on the green on the right, it shows the cost. And so for osteoporosis here, we have the Best Buy drugs are about $40 per month for the patient. There are other drugs on here that range anywhere from $200 to $1,500 per month. And there may be the isolated patient who really needs those drugs, but most patients shouldn't be started on those $200 to $1,500 drugs. They should be on drugs up in the top area of this chart and the more cost-effective. This just shows the relative prices of these drugs with the $1,500 truncated, just so you can see the other things on the graph. So the Best Buy drugs are the best value. And again, it's based on safety and effectiveness first, and then costs after that. They provide evidence-based preferences. They serve as a means to get more value for the dollar, the Best Buy drugs do, and they help patients get safer and more effective therapy. Sometimes we've forgotten that the old generic is still the preferred, safer, more effective drug in a therapeutic category. I've actually taken the Best Buy drugs and applied it to a formulary, and I found for at least the formulary I examined, which was actually a pretty good formulary in the first place, that if you use Best Buy drugs 85% of the time, that's assuming that 15% of the patients still need those other specialized second line of choice drugs. If you used it 80% of the time, you could save anywhere from a low of 17% in the statin category, and this is before the PCSK9s came out, and to a high of 78% for antihistamines. So Best Buy drugs, when a safety and effectiveness that's evidence-based and then lower cost applied to a formulary, can provide safer, more effective drugs, and in this case saved up to 50% of the total drug cost if they were used on that formulary as the predominant choice. And again, this is not forcing them on people, this is making the safest, most effective choice. So what does the future hold? What does all this mean? Doctor, how sick am I in dollars and cents? We need to encourage patients and providers to talk about real costs of choices in healthcare. Real choices, real costs, not list prices. We need a system that has transparent costs and prices. I just entered the Medicare generation and recently had a colonoscopy. And when I went in, I asked, now how much is this going to cost? The receptionist says, oh, I don't have prices here. I can't tell you that. Well, can you find out for me? Well, no, there's nobody here that can tell you that. This is not a market. This is not a healthcare system. Now, I'm not telling you I should make a decision based on what I hear there, but I should be able to find out what the cost of my care is going to be when I'm getting it. We need patients and providers to talk about real costs and real choices. We need to make sure that our innovation doesn't end up like this. Do a double-blind test, give the new drug to the rich patients and a placebo to the poor. No sense getting their hopes up. They can't afford it even if it works. Well, sometimes this happens in healthcare today. Patients can't afford therapies that work. That troubles me because there are times where we waste resources on drugs that aren't needed and cost too much, and then drugs that may cost a lot but are really life-saving aren't available to patients who need them. We need to use our resources much more wisely. We need innovation around value. A quick comparison, computers, the price of a supercomputer back in 1975 cost $5 million. The price of an iPhone, like my students use today, with equal or greater performance capacity than that supercomputer, costs around $400. So let's look at pharmaceuticals then. Pharmaceuticals, the price in 1975 of the average prescription was $5. This is not the copay. This was the average prescription price in 1975, $5. Today, the average prescription price is around $400 or $500 even now for brand name drugs. And if we're talking about specialty drugs, it goes up even more. So on computers, our value has been to drop 12,500 to 1. For pharmaceuticals, we've increased prices by 1 to 80. And then if we look at specialty drugs, they're priced around 3,500. So that's increased 1 to 600, 1 to 7 or 800. So we haven't done very well on innovating with respect to value in pharmaceuticals. We've had innovation, but we haven't had value innovation. I think there's a need for value, and how can we improve value? We need to value innovation. It is important, we value it, but we need to have innovation in delivering value. This is one of the biggest holes, I think, in our healthcare system today. How do we develop innovation at delivering value that is more care at the same or lower cost? How do we learn to use our resources more wisely? Increased value will result in improved health outcomes for more people. I thank you for your time and attention. Keep swimming upstream and fast. Thank you.
Stephen, people want to hit you kind of hard here.
Okay.
So why does innovation come into it? If it's a $100,000 pill and it needs to be made available for $50, cut the price. What's the innovation that's needed?
Well, there is a cost to discovering that new drug. I don't think the numbers that are normally thrown around are necessarily accountable or validated, but it's probably more than $50. So I think we need a process where we can determine what does it cost to bring that to the market, how do we appropriately reward innovation and continue to stimulate it, but not pay for things that are marginal innovations like new dosage forms, new strengths, and get 20-year patents on things that really aren't new drugs or new therapies in the market.
So you would criticize the industry for focusing on Me Too drugs and development of imitation drugs as opposed to investing in fundamentally new therapies?
I don't criticize the industry for it. I say the economics favor that. If I can invest $50 to $100 million and come up with some new dosage forms and get a patent and have patented prices continue for 20 years, as opposed to spending $1 or $2 billion to find a new therapy and not have all that much more revenue, my ROI is going to be more on the one that was cheaper to find innovatively than the one that costs more. So I would favor the cheaper innovation. So if that means criticizing them for Me Too drugs and follow-on products, yes, I do.
What would you say to Martin Shkreli if you could talk to him?
I would say don't get into drugs. You don't know anything about it. The lines he's used the lines of the pharmaceutical industry, but used them very disrespectfully. And even the pharmaceutical industry has distanced themselves from Martin Shkreli.
Well, yeah, but what would you say to him?
I wouldn't speak to him.
Really?
Yeah. I don't think he would want to. I'd be glad to have a dialogue if he wanted to have a dialogue, but I don't sense from his presence in the presentations he's given that he wants to really look at the value.
But from the consumer standpoint, is there any difference between the CEO of Pfizer and Martin Shkreli? I mean, if it's just some random person setting a price, I don't necessarily have a notion of why it's more expensive from one or more valid from one than the other.
And we don't know. I'm not sure we have a lot better evidence from either about what the true cost and value of the drug is. And the value probably has nothing to do with the cost to the manufacturer making it.
Isn't that a complete outrage? I mean,
well, it has to do with what does it do to change the life and outcome of a patient's health. That's where we get value, not from how much is charged in the market.
But that's something you only know after you use the drug.
You may, but I don't think we have a marketplace that provides feedback on prices and comes to a market-based price, even though we call it that. I believe in market-based systems. Drugs aren't one.
A couple of people here think that consumers need to be educated as to who is really paying and what they are paying, that consumers are encouraged to think that drugs are essentially free. Do you believe that?
I believe consumers have that perception, and many in healthcare have that perception and encourage that in consumers. I think we need to do things to make the cost transparent to the consumer, even if they don't have to pay the full cost. For example, an explanation of benefits, and make sure, and the pharmacist needs to have the data to do this, but at the time you get a drug from the pharmacy, they could give you, here's the total net cost of this drug in the system. And we need to make sure, just like we track and trace drugs through the manufacturer to wholesaler to distributor to pharmacy to patient, we can track that at the lot number to individual pill level. We could tie the price to that too and take all discounts, all rebates off and say, here's the net cost. But everybody along the way, manufacturer, wholesaler, PBM, providers hide the prices and have shell games that are going on. And so we don't know, most providers, as I said, don't even know the price at the end of the day. I think we need full transparency and need to tell the patient what that cost is and how it affects their insurance premium the next year.
Should coupons be outlawed?
I would consider that because I think they really do induce inappropriate behavior with respect to both drug decision-making and with respect to cost use in healthcare.
Well, I mean, if you want transparency, you got to get rid of the coupons.
Yeah, I said I would support that.
You say you have to consider it.
Okay.
All right.
Well, I'm not the decision maker.
No, I understand.
But I will recommend it. I will discuss it, evaluate it.
Should we stop making drugs to treat orphan diseases?
No, that is not the point. I fully support and encourage drugs to treat orphan diseases, but we have to find a business model for valuing and pricing them that works better because the current one is not working well.
Do people need to view the value of their life as their own fiscal responsibility and not their inherent right in the healthcare system? In other words, is there a social compact involved in this calculation of the value of your life, or is it something that is totally your responsibility and you have to plan for it from the moment you're born?
Are you asking, am I a Republican or a Democrat?
Very astute.
I don't think there's an answer to that either way. I think people have responsibility for their own life, but society also has responsibility. I believe healthcare is a right, but not all healthcare can be afforded by any society, including our wonderful American society.
Do pharmaceutical companies take advantage of the system because of its flaws, whatever their intention?
I believe pharmaceutical companies use the system to maximize return to their shareholders, which isn't the same as saying they provide the best value for the health of Americans.
Stephen, thank you very much.
Thank you.